Thank you for joining our Policy Committee meeting. This meeting is being recorded. The documents which will be discussed here today are available on our website, which is wmc.wa.gov. I am Amelia Boyd, and I am the Program Manager for the Medical Commission. I, along with Jimmy Bush, are the organizers for this meeting. Panelists, please make sure your line is muted if you are not speaking. Dr. Karen Domino is the chair for the Policy Committee. Once a presentation is finished, Dr. Domino will open the floor for committee and public discussion. Attendees, if you would like to ask a question or speak, please use the raise your hand function or the question section. And with that, I will hand it over to Dr. Domino.
Hello, everyone. Welcome to the Policy Committee meeting. I was just had a lot of papers on my desk, and I just found the papers for the meeting. So the first agenda item we have is the proposed policy for establishing approval criteria for defining appropriate medical practices for IMG nomination. And then we have this in front of us. I don't know, Mike, I have a very small computer. Can we make that a little larger for us to see? Great. I'm wondering if anyone has any comments to it. To me, I think there are some changes to this policy on the second page of it in red, and I felt it was fine. My only question about it personally was the punctuation, whether some capitals need to be inserted for words like Department of Corrections, which strikes me as a name, or whether semicolons need to be submitted. So it was really just one of the, something like that. But I'm wondering about anyone's comments about it.
Karen, I found it to be very well written, and I would like to approve it as is with the appropriate editorial changes to make it be grammatically proper.
Yeah, and Mike, do you want to, thank you, Alden. I thank you, I appreciate that. Mike, do you want to say something? Because some of this, we were dealing with this before, and I think you mentioned that we went back and made the changes on page 2 in response to the concerns of our IMG physicians. And so I thought that would be important for people to know.
Yes, Micah actually took this back to the IMG folks and the physicians who would be supervising them and got their feedback, and this is what they came up with. So I think this was a good stakeholdering work, and this language seems to be agreeable to everybody, at least that we spoke to. Regarding the capitalization, that's an important topic for me. I assume you're referring to the statute where it says Department of Corrections, and the Code Revisor's Office.
I guess it is. Oh.
Yeah, almost everything in a statute is lowercase. So that's just the way they do things. We can't change it.
Oh, okay, thanks for clarifying that.
And this is Heather. Yeah, I just wanted to say one thing, just to remind you that this is a policy statement, so it's advisory only. It's not a legal requirement, and so I would recommend that you can adopt this, but that you consider doing this as a rule so that it can be enforceable, because as it is, a policy statement is not legally enforceable. So while this is guidance and advisory, it doesn't have the weight of either a rule or a statute. So that's something to consider. And also that the policy will also have to go for review to the secretary. So just those two things.
Thank you, Heather. Any comments about that? It seems reasonable to move it, for a review or rule eventually, because we would like it binding, right?
Yeah, we're doing a policy, and it will go for secretary review, but we want to get the policy in place so that we have some structure for IMGs who are ready to work now and have applied. And as you all know, the rulemaking process takes a little bit of time, so it's important to get this in place first.
Any other discussion over this? Can we have a, you know, a motion to accept? I guess Alden's essentially a motion. I don't know if we need a second to accept this. Yeah, good. Thanks, John. And then all in favor, say aye or raise your hand. Anyone opposed? Great. Really nice work, everyone. Mike and Mika and our IMG group of physicians. So the second one is kind of the second part of this. This is aimed at the practice agreement. And this one is page 39 to 40. And Mike's getting this up now. It looked to me to be fine. The only question I had is the issue of being in the same specialty, since some of these individuals that I know of have only gone to medical school. Perhaps they completed an internship, but don't have a specialty beyond being a generalist. So I didn't know how you were going to deal with people who also went to, you know, I mean, you in certain areas, like I suspect in surgery or certainly in anesthesia, you don't have much training of that in medical school, and you can't say, hey, I want to be a surgeon, and then you come out and expect to do surgery or expect to do anesthesia. It seems so it's different if someone's already trained in their country, where we're then having these same specialists and working in that area makes sense. But for those who are generalists, particularly just out of school from other countries or have done an internship or an observation here in the US, is what specialty do they work with?
Should that be revised to kind of a within scope type of language instead?
We're dealing with the language of the statute, not our interpretive statement. It can't be changed.
Can't be changed. All right, but the commission could have some ability to make a decision of what an appropriate practice is, right? So I mean, I know, for example, I know someone who wants to be an anesthesiologist. She trained out of the US. She actually did an internship out of the US. She passed her USMLEs, and she worked as an ER doc, I think, for a year. But so she'd have to work in an ER, is that, you know, or what? Or if you don't have that year and all you do is a general internship, I don't know where we're going to put them.
So I think the statute, Karen, requires practice experience before you can get into a residency, or most residencies won't take you without
Right.
without experience. And this may be all that's necessary for somebody who's come out of a medical school and hasn't done a residency, because they would be fine to get into a residency.
Right. So no one I mean, you know, so someone wants to do an internal medicine, which is a general area, right? They're doing an internal medicine experience and they want to become a surgeon. Isn't that okay? Eventually?
So yes, but I think what this requires is clinical experience prior to being able to get into, I may be overreading this, but clinical experience prior to getting into a residency. If you've done a residency, that's a different situation. And I think if you get the clinical experience, I'm not sure, I guess maybe I'm saying the same thing you are. If you get the clinical experience, why does it?
Exactly the same thing, but it's written in statute. So the language is what it is, but when we interpret it, I think we need to interpret it a little broadly.
Is there anything that defines specialty as used in statute in these sections?
I don't think so, but it sounds like these are issues for panel L.
Yeah.
The only thing this document says is that the The IMG has to file a practice agreement before beginning practice. That's the only thing this document says.
I'd like to make a motion that we accept it as it is, but further discussion is also encouraged.
Yeah, anyone else agree about
Well,
any
I'm
other?
just wondering what's in the practice agreement generally.
Can someone tell us, Mike?
I'm going to pull up the whole statute here.
And Marissa is here as an attendee if you'd like her to respond.
Sure.
Go ahead, Marissa.
Hi, this is Marissa Courtney. I'm the licensing manager. So what we have laid out in the practice agreement is basically just an overview of what exactly is going to be the general duties that are going to be supervised between the MDCE and the supervisor. So we asked for the name of the MDCE, so the IMG. We asked for the name and credential information for the or license information for the supervisor. We asked for the location that they're going to be practicing at and the general duties and how they plan to supervise. Those are kind of what we've taken from our PA delegation agreements or practice plans. The law or the bill really didn't have specifics, but we knew that at least this was something that we found in the past that this information was good to have. And then if it ever is revised in the future, we could build on that. And it does cover specialty. I'm sorry, I forgot to add that too. I think one of your questions, as you stated earlier, is how do you determine specialty if a person comes out of medical school? We've had this discussion, and it has come up with our medical or international medical grads who did just complete medical school, and they don't have an actual specialty defined yet. Micah had stated that we are, it's basically up to the provider and their supervisor and the company where they're going to be working at what specialty they will be performing under if they haven't established one and at least had, basic training in that role.
Okay, thanks. That's very helpful.
Okay.
Any other comments? No? Do we have a second for the Alden's motion to accept it? Great, Scott, thanks. All in favor? Raise your hand. Anyone opposed? Okay, that passes as well. Right. This number 3 is the personal data questions revision. This was a draft. I thought we approved this before, at least we discussed it. And then we talked about it a little bit at the meeting. And then Mike, were there some changes made as a result of the meeting? I think there was some discussion about it. And I don't know if these red things are the changes or these were the original changes.
Yeah, this was revised by Micah, and I think Marissa, you can speak up if you were involved in this. So Micah is not here yet, I don't think. Are you, Micah? No, he's not here yet, but he did say to go ahead. I know that Dr. Roberts had some issues with this and some suggestions.
Yeah, I think they're fairly minor, but I'd like to bring them up anyway. On page 2, question 1, we make the comment, let me see if I can get to it here. We make the comment, do you currently use any substance that alters your mental facilities, that impairs or may impair you? And then you may answer no if you are let's see, have you, you can answer no if you are with a, with WPHP or with a HP organization. And I don't like the idea of saying you can answer no when you do have a problem. And I'd like to say, and I'd like to add to it, if you have a problem that's not being managed by a physician health program.
Well, we have a safe harbor kind of question now that says if you are in a PHP program, you can answer no, but this one seems to be different than that.
I think it's the same. It allows you to answer no if you're in a PHP program, but the problem is the answer is yes. And that bothers me. And I think we should include the exclusion in the question.
Mike, were these changes made from before, or is this how it originally looked? Because
These changes were made after you last looked at this.
So
The
was
changes
that
are
from Dr. Bundy who wanted that change?
It's involved. Amelia, is Dr. Bundy here?
No, he is not. Oh, yes, he is. I will unmute him. He is self-muted. Dr. Bundy, are you there?
I'm unmuted now. Thank you.
There.
How can I help?
Chris, my concern is that we are still allowing somebody to say no. I think the question is not worded properly. We're allowing somebody to say no if they are registered with a PHP. And rather than say no, I think if we remade the question so that it says if you're registered with a PHP, you don't have to answer. I'm sorry, so that the question says that is not registered with a PHP.
Can you scroll up in the document? Because I think the relevant language around that says that you can answer no to question 1.
Correct.
Are known to WPHP. And so the use case is that somebody who would answer yes to this question is somebody who's not known to WPHP, who's currently using a substance in a way that impairs or potentially impairs their ability to safely practice.
Right, but the only thing, and this may be minor, it's kind of not in my mind, but it may be minor, but the question isn't phrased right. The question ought to be phrased in a way that allows the individual to actually say what's true. And that would be something to the effect of that they are, I'm actually having trouble finding where this is located, but that says,
Paragraph
rather than
1,
saying,
no, just under that.
I'm sorry, say that again.
Paragraph 1.
Yeah.
It's at the end of the paragraph with the language. You can see
Yeah,
it there.
thank you.
Say no.
Thanks. Yeah. So it says, the question says a medical condition includes any of these disorders, and we don't inquire about substance abuse of applicants. And if you're with WPHP, you can say no. But rather than do that, I would rather the question actually ask, do you have a medical condition that includes social, behavior, physical, or whatever, and then add to that is not currently being managed by a physician health program. And managed may be, yes, you've looked at it and said you're fine. And that would allow them to say, no, and they're actually answering the question truthfully, rather than saying you don't have to tell the truth if you're with the PHP.
I think I understand where you're going, Dr. Roberts. If you scroll down to the question 1, instead you could say, well, I would rephrase this slightly even at the beginning to say, do you currently use any substance that impairs or may impair your ability to practice your profession with reasonable skill and safety that is not known to the Washington Physicians Health Program?
Yeah, exactly. And it can, rather than limit it to just Washington Physicians Health Program, which I think would exclude people that are applying from out of state that are registered with another physician health program. If we could word it the way you did with a physician health program included, I would feel better about it, because then you could tell the truth.
You could say that it's not known to a physician health program.
Correct. It's a fairly minor change, but if you're talking about a population that you're encouraging to tell the truth, it's a change which, in my mind, seems significant.
Yeah, Alden, I like your change because I feel, I mean, you want people to be honest, and it just seems weird to say no when you know.
When the answer is yes.
Yes, when the answer is yes. Makes it hard to really understand the first paragraph then, which introduces it. I mean, what you change for the question, I think, is good. I think the first paragraph needs to have that changed too.
So I do have a question about this. Does that mean that if someone on their own enters 12-step work and goes into therapy and does a whole bunch of stuff to prevent a substance from interfering with their life, that doesn't count because it's not a WPHP format?
It wouldn't count under the way it's presently worded either.
Right.
I think your question is well made. I would say that if you look at the wording on 1, it would be that you're using the substance in a way that impairs or may impair your ability to safely practice. So the question asks currently, which means in this sense, in the last 6 months, have you been used? So I guess the loophole, if you will, or the negative loophole is that somebody could have quit using substances on their own in the prior 6 months and be attending their own recovery program and process and treatment, and they would still be required to answer yes to this question if they were unknown to the PHP.
The thing is,
I think you have to ask yourselves the question of, do you want to admit an applicant who is in that early stage of recovery who is not known to a PHP?
And Chris, that's the catch. And my knee-jerk reaction is no, I don't want to, because there's a big difference between recovery programs and PHPs, particularly the WPHP. And I think as it relates to patient safety, those that are with WPHP provides a layer of safety that we will not get from any other program.
I have a question. Do you know if anyone has ever answered yes to this? Has they ever said, yes, I am using a substance that impairs my work?
Well, one of the things that this does for us is if they are, it's a slam dunk in being able to do something about it because they lied on their application.
As I understand
And how
it,
many people have we found that have done that?
Probably none.
I mean, that's the point. Is this really a functional question? Anyway, I might be going down a rabbit hole with this.
I think as you know that its initial licensure is a unique time in an individual's trajectory in the regulatory environment where you have to potentially evaluate admission versus not. And so I guess from my perspective to your question, Dr. Trescott, it may be that you're really looking at somebody who's in very early recovery, seeking licensure in the state, who has very recently gone about a program of recovery that may or may not work for them. Some people can stay sober without the need of a monitoring program, but some people cannot. And for folks who are seeking, they could wait. They could wait to. I mean, I guess I would look at it too as what is one of the effects of this. One of the effects might be that an individual who's early on, who reads this question, who does want to answer honestly, might decide to delay their application a little bit longer. If they are indeed going to answer honestly, to make sure that they're outside that 6-month window, and that maybe you're sending a message to applicants that we don't want early people in recovery who are not known to the PHP to be making an application at this time, that maybe that's not the time to be making an application. So there's what the question asks, but there's also sort of what it covertly asks, if you will.
So there also is a case that we just had in Panel L of an individual who we knew had a problem from a police report, and they weren't answering truthfully on their application. They subsequently did get involved in a program and is probably going to end up being okay. But yeah, there was one that we could have dealt with and we're going to deal with.
Dr. Domino, this is Micah. So just to answer Dr. Trescott's question, I just got a message from a staff member at the osteo board, and they said that they do get false positives on this question about drinking glasses of wine on occasion. So that does come up.
Okay, do we need to change? I mean, Alden proposed a change, or Dr. Bundy did, on question 1, but the first paragraph, is there something we can propose a change there to make it consistent, or do we want to think about it and do it on our own time and bring it back next time? We'd actually, I think, almost approve we got additional feedback, and it would be good to move this along if it's possible.
If you just take out
I
the part
like the changes Dr. Bundy suggested, I thought.
If you just take out the part, that says you can say no if you're registered with PHP, it says what we want it to say.
That's the last sentence in the red, the underline.
Yes.
And then we added the down. Mike, did you get the thing, the stuff down below in question 1?
Not exactly.
Okay, I think it's take out that alters your mental function.
Oh.
So this is Melanie. I want to answer Dr. Trescott's because it took me a bit of time to find this, but I ran a query of how many times people answered yes to that question. So from 2012 to 2017, the question at that point was, do you have a medical condition which in any way impairs or limits your ability to practice? That question, 57 people said yes over those period of years. And then question 2 was, do you currently use chemical substances in any way which might impair your ability to practice? And for the same number of years, 12 to 2017, there were 14 affirmative answers.
Great.
However, no one ever answered yes to have you ever been diagnosed with or treated for pedophilia, exhibitionism, voyeurism, or frauderism. So we took that one out.
It should be noted that as soon as we took that out, we got 3 cases of frauderism, just
Yeah,
so
that's
we're clear.
very true. That's very true.
Okay, so question 1, do we want Dr. Bundy to rephrase that rather than what I wrote down that he said?
Well, I think Dr. Bundy's the right person.
Oh, am I still unmuted, Amelia?
We can hear you
Yes.
now.
Okay. So I would just say, do you currently use any substance that impairs or may impair your ability to practice your profession with reasonable skill and safety that is unknown to a physician health program, or that is not known to a physician health program?
Move that we accept that as that particular phrase.
Any other discussion? Did we get that down so it's all there correctly?
It's a PDF, and Amelia's
I
in charge
see.
of that.
Yeah.
Can I read
Good.
it back to you, Dr. Bundy and Dr. Roberts? Do you currently use any substance that impairs or may impair your ability to practice with reasonable skill and safety that is not known to a physician's health program? Okay, thank you.
That's it.
Okay.
So
Great.
I just want to clarify with the change in the first paragraph of the "you may answer no" piece, and that change in 1, you are preserving a safe harbor for mental, physical, and all the other types of conditions. And I just want to make sure that my understanding is we're preserving a safe harbor for chemical substance use or substance use disorder in question 1 with this change. Is that the understanding of the group? Because that was the original intent.
The intent is to provide a safe harbor for all of those above, including the chemical dependency, if you're with a PHP and PHP
Okay.
and functioning.
The way I read question 1 now is they are outing themselves about being with PHP.
No, because everyone has to answer that question, whether you have a chemical dependency or psychiatric disorder or not.
Right.
Okay.
It's a kind of a double negative problem, I think, too, Micah, if my brain is working properly. Which means that somebody can answer no to that when they are known to WPHP. So by answering no, they are not outing themselves as being known to WPHP. They know that they're known to WPHP, but you don't know that they are.
Got it. Okay. It was like a quadruple negative or something. So, all right.
Yeah.
All right. I just want to make sure we did not inadvertently lose that safe harbor piece. Thank you.
Any other comments?
I just have to say,
Oh, sorry.
it's awfully confusing. And it is, by virtue of everybody's conversation, it's confusing. And we're trying to get at an answer through, I think, what did Micah just say? Quadruple negatives. Isn't there a way we can word this that's a little more straightforward? Or maybe it's just me. Simplicity.
So John, I think it actually is straightforward because the question becomes simplified. Do you have any of these problems that are not known to a WPHP? And if I'm answering that question, I don't have any of those problems, I answer no. If I answer this question and I do have some of those problems, but PHP knows about me, I still get to answer no.
So then are we going to alter the first paragraph, last sentence? Is that going to be deleted, or does that remain?
It would be deleted because it would be
deleted.
That's what I was, okay.
That's what Alden
makes
proposed.
sense.
Still on that, because that's a PDF, I guess. So.
Okay, got it.
Can I?
I agree that the language proposed by Dr. Bundy makes sense. It's just very clear, it's straightforward. But I was still confused with the remaining language, and I understand that's now gone, so, okay.
I
Any
just
other
the
comments?
key to suggest if I'm able. I don't know if you can hear me or not.
Yes, we hear you.
Thank you, Amelia. Instead of saying in the first paragraph, safe harbor provision, in our world, that's actually called a safe haven provision. It seems like a small edit, but a safe harbor in some quarters might suggest that it's a place where doctors that could hurt people are allowed to be. So safe harbor is it's just a little bit different. I might call it safe haven.
Well, Chris, we're in a coastal area, so harbor and nautical terms is what we trend towards. But I understand and would support the change if it would reduce anxiety for folks.
Agreed. Agreed.
Me as well. Any other comments? Alden made a motion before to accept it. Alden, it sounds like you like this haven as well. Do we have a second to accept those changes? Thank you, Claire. Scott? And all in favor? Say aye. Raise your hand. And anyone opposed? Okay. Thanks, Dr. Bundy, for all your excellent expert advice. And Dr. Roberts as well.
This is a wonderful piece of work that you guys have done here. You're really leading the pack.
Well, thank you for your consultation on this, Dr. Bundy. That was really appreciated for you reaching out and giving us some help with the language.
You know, I think it's wonderful that we have this in here and that we talk about it. It'll kind of knock down a little bit of denial in practitioners who may be practicing under the influence. I think it's an excellent question to have in there, just so you know.
Will this document, will those changes be ready for tomorrow's meeting?
It's a pretty minor change. I would hope so.
Mike, will you send it out to all the commissioners?
I don't have the Word version, and I don't know who does. Micah, do you have it?
I have the Word version, but I haven't had a chance to get it open yet. So if you have taken notes on what the changes are, could you send them to me via email, and
Yep.
I will make the changes and send them out tonight.
Yep.
Okay, thank you. All right, the next one is on telemedicine policy statement. Mike, do you want to fill us in about this?
I do. There's a new version, and Amelia, I'm wondering if you got that email from me. If you wouldn't mind sharing the Word document that I attached and putting it on the screen, that would be helpful. There you go. Okay, you have seen this before. You approved it to go for secretary review. So that's the process that took place since the August meeting when you took a look at this. The Secretary's office took a look at it, and they made they made a number of recommendations that we incorporated here. You'll see them in red, but I want to begin by saying that they recommended that this be either a guidance document or an interpretive statement rather than a policy. And I know you're going to say, well, what is the difference? There's really not a big difference. Policy statement, which is what we're recommending that this be, that Mike and I think are appropriate, has a definition in the statute, and the definition is it's a written description of a current approach of an agency to implement a statute or other provisional law, a court decision, or agency order, including, where appropriate, the agency's current practice, procedure, or method of action based on that approach. So this doesn't really fit that statutory definition, which is the point made by the Secretary's office. However, it's really a combination. This document is multifaceted. It's a combination of a guidance document, an interpretive statement, and a policy statement all in one. So you have to choose one or the other. So what's the difference between a policy statement and, let's say, a guidance document? A policy statement, first of all, goes through secretary review, and then the notice of adoption is filed with the code revisor's office so that members of the public can see that and find out, at least if they go to the code revisor's office, can see that policy and get access to it. If it's a guidance document, it doesn't do that, but it is put on your website and disseminated. I also know that some of you have an issue with calling these advisory documents guidelines because clinical guidelines are a completely different animal. So I think, and if Mike is still on, yeah, you are, I would recommend you go with a policy document even though it doesn't fit the statutory definition.
And I would just echo that. So think of this from a customer service standpoint. That's how I approach it. If we were to accept the recommendations, it would involve parting out what you see in this document. Part of it would go to an interpretive statement, part of it would go to a guidance document, and perhaps part of it would go to policy. So for the same subject, you are going to send your licensees and everybody who works with them to 3 different documents to understand what we mean as a commission about telemedicine. And to me, it just doesn't make sense. I think if that's where we were going to go, then we would need to trim this back significantly and choose a pathway and only address those things that are addressed in that pathway. I think you're safe in choosing to go forward in a policy document, and I think that's kind of the expectation of stakeholders as well, as something that is easy to access, that is consolidated, and most of what's in here will really set the course as far as what the medical commission is deciding is appropriate with respect to telemedicine.
Any thoughts about that? I agree, Mike. I think that clarifies things for me. I like keeping it in a policy statement. I think it's an important thing, you know, for the practitioners.
Okay, so big picture is this document does 2 things. Number 1, it tells a practitioner when they need a license to use telemedicine in our state. So that's section 1. And then the bulk of the document provides guidance on best practices for using telemedicine. So to go to the licensure requirements, thanks, Amelia, they're right here. It begins by saying that the general rule, you have to have a license if you want to practice medicine in the state of Washington, unless you fit within an exemption. And then it talks about one exemption specifically for telemedicine that was passed at the last legislative session last spring about consultations. And then it goes into circumstances that aren't quite covered by the law, but based on our experience with the way you operate, are examples, we believe, are examples of situations where you would want to allow a physician not licensed in the state of Washington to treat a patient within the state of Washington. So I don't know if you've had a chance to look at this. I know you looked at it back in August. That red paragraph there is not new. It's a revision, a clarification of the one that was in there before. So it allows a patient to get a second opinion by a specialist out of state by sending records to the specialist to review. And we're saying that is the practice of medicine, but it's exempt from the licensure requirement. If the patient undergoes treatment by that physician, then the patient either has to travel to, let's say, the cancer center for treatment, or go under the new statute, which allows the patient's treating physician in Washington to have that consultation physician to physician with that out-of-state physician.
Any comments? I thought it was very clear.
Yeah, that makes a lot of sense.
Yeah.
This is actually an example that is drawn directly from patient complaints basically about our current stance and policy that it's not as clear about that. That we received through the governor's office. We received multiple complaints during the pandemic about this, how out-of-state cancer centers have concerns that they cannot offer these services. So that's one of the reasons for the specificity on this.
So I have a question, living in a border town, and that is that what if we have, does this somehow or other include a patient who is normally a patient over in Portland, but doesn't need to go see their physician for every visit? They can do telemedicine visits occasionally and go in person occasionally, but in person they always go to the guy in Portland. Do they have to have a Washington license to do that?
I think if you reversed the scenario, it would make more sense. So our jurisdiction stops at the border, obviously, and you know, you doctors in Washington are under the good graces of the Oregon Medical Board should you try and do the scenario you discussed. But if we have a doctor in Portland who is not licensed in Washington, patient lives in Vancouver, normally goes to see them. This is actually what started a lot of the guidelines and the continuity of care policy of telemedicine was an inquiry about that. And so it's up to the medical commission to say it's okay for care coming in to not require a license. And so that's what you did in your continuity of care policy. You addressed that exact issue. So if someone was feeling ill and they wanted to call in or have a video chat with their Portland-based doctor and they're just getting a triage, that's allowable under your current continuity of care policy. That is translated as allowable under the policy that you see in front of you.
Great, that's what I just wanted to make sure of, Micah. Thank you.
And just to be clear, if you adopt this, you should rescind your continuity of care policy. It's outdated, so this is meant to replace that.
And the guideline, or unless we've already done that, correct?
Both.
Yeah.
You have an old guideline from 2014. You've got the continuity of care interpretive state or guideline policy. Rather, you're getting rid of both of those because the concepts in both of those are put into this document.
So you're getting a 2-for-1 special.
So can I ask one more question? Under the appropriateness of telemedicine, which is page 47 of the big packet, and I'm probably about 5 of 6 of this packet, we make the comment only the treating practitioner may determine if telemedicine is appropriate for a given patient encounter. Why do we need that sentence? The remainder of it just takes care of everything. And if somebody does something outlandish and says, well, you said I'm the one that gets to determine it, why do we have that sentence at all? Why does it help?
So the reason for including that is to counteract any possibility of corporate practice of medicine issues. We saw this early on in the pandemic where practitioners were, well, they were fearful, frankly, of being or saying to their leadership that I don't want to do telemedicine. I don't want to do it for various reasons, and those reasons can be appropriate. If they're simply not comfortable with it, that's fine. So it was originally empowered. WISMA actually asked us to make the change to may determine, and I think that's fine. But I think throughout this document you see the empowerment, or for lack of a better word, of the physician to make the decision on whether care is appropriate. And I think we want to stick with that concept to avoid what surely is happening in direct-to-consumer telemedicine companies and contractual telemedicine companies, where they're getting their directives on what they can do via telemedicine or what they will do via telemedicine. And I think that standard of the commission saying it's on the treating practitioner to determine appropriateness, not someone who's not a treating practitioner or someone who is a management entity.
So I'm not going to recommend that we make any change on that. It makes sense to me that we're trying to protect something a whole lot bigger than the really unusual situation in which somebody does something outlandish. It's possible it could be worded better, but I wouldn't worry about it. I think this document is a pretty good document.
Any other comments about the document?
One item that I would point out that, sorry, Amelia, that I should at least raise is if we go to the artificial intelligence section, it was brought up by WISMA that they don't think that's appropriate for this document. And I committed to bringing it up to the policy committee to consider that. Technically, artificial intelligence is not telemedicine. It does tangentially affect, it does intersect to some degree, but it's not telemedicine. So if you feel that that's not appropriate for the document, no harm, no foul. We can address it in a separate document if we want to talk about that. So for your consideration to keep or delete.
I would keep it. I like it.
Other folks?
So we do have a hand raised, and it is Katarina from WISMA. Katarina, if you'd like to go ahead.
Hi, yeah, thank you for the opportunity to comment. In the interest of time, I know we don't have very much of it left. Just with respect to the AI provisions, we just didn't feel that they were germane to the policy, so that's why we wanted to request that they be removed. And then we also just noticed the mobile technology piece is largely a restatement of federal law, so that could be removed also, but it's clearly up to you. And then I just had a question regarding the patients who are seeking out a second opinion. What you said earlier is actually really helpful and I think provides a lot more context. We were just wondering how opinion or consultation is necessarily defined, and do you feel like this adequately protects against an out-of-state physician from providing more than an opinion, like a diagnosis or example? I don't know if anyone can speak to that.
Any comments about that?
Diagnosis is an opinion, so.
It is an opinion, yeah, diagnosis is an opinion.
Would that be, I guess my question is then, would that be considered providing, I guess if you're diagnosing someone, are you necessarily treating them? I don't know. I'm just trying to figure out where that stops.
You're treating them. I mean, I've seen in my, one of the cases I reviewed for the commission this time, there was a complex case and the family contacted physicians in 3 other states from academic institutions or specialists in the area. It was not to take care of the patient. It's just they were just trying to find out, maybe to figure out what was happening to this patient due to the complexity of the diagnostic and treatment aspects.
Okay, so, yeah, and if that's not of concern, then.
Yeah, I mean, to me, it's a consultation. We often consult someone to help us figure out what might be happening to someone.
Yeah, I guess it's more just in the context of a patient directly seeking out that versus it being like a peer-to-peer physician to physician. And then just a quick comment regarding the use of the word should. I know we typically wouldn't advocate for the use of mandatory language when it comes to the provision of clinical services, but since this is more about the method by which the service is provided, we just had a bit of concern about its use in instances where it would create sort of conflict with the standard of care versus in what's required for in-person treatment. So I don't know if there's any way to ensure the quality is not diminished for the use of telemedicine and compared to in-person, but if you all had any thoughts on that or had considered it, just wanted to know your thoughts.
And to address that, I believe we accepted those edits from you all, Kat, and so the shoulds have been changed to shalls in this draft, unless I'm wrong.
What part of the document are you referring to?
All through it, basically. Oh, no, maybe not. Okay.
It wasn't on mine that I saw, but just for consideration.
I think shoulds are in there because it's a policy rather than a rule.
Okay.
Are you saying you prefer must or shall?
I guess it's hard to say, but just where it could present a conflict with what would be required for in-person care. We just don't want the standard to be less for, yeah.
Oh, okay, I get it.
So with respect to follow-up care, medical records, privacy security, those would all be shalls because that's what you have to do with in-person.
Yeah. Yeah.
I tend to think of shalls and musts and wills as being more rulemaking rather than policy or guideline. Certainly the intent is not to lower the standard of care for telemedicine.
Right. Yeah, just didn't want it to be interpreted as such.
did we want to change a word like instead of should, you can convert to will? Have access to, adequate knowledge of? I mean, I don't, is that what you're saying, Mike? Will?
No, I'm not. These aren't perfect words, but I would recommend staying with the word should, because you're, in a sense, you're setting a standard of care, telling practitioners you should do this or that. When you say shall, then that really sounds like a rule that a violation of which would result in enforcement. This is a guidance document to practitioners to practice better medicine. If you want to move to a rule, we can do that. Actually, we just did that, and that's why we're here now.
Okay. Yeah, no, that makes sense. And that was all I had.
And I think with respect to enforceability, to address Mike's question, you can use policies to bolster your disciplinary action. You have a policy on disruptive physicians, and you have used that and cited it in your disruptive physician actions before. So to have it be should, I think could work the same way. If you cite a substandard use of telemedicine and use your policy as that, I think that is acceptable.
Okay, great. Thank you.
So any thoughts about the artificial intelligence? I think Alden said he liked it. I didn't feel it actually fit, but I didn't have a strong feeling about it.
I like the statement. I take Wisma's comments about that section as well as the mobile medical technology.
Anyone else? Claire, John? Alden?
I just question whether it fits or not, but I don't see anything wrong with the statement. But
Well, for one thing,
I guess you could still use it, and it's still applicable. So I don't know.
one
I'm being
reason for
wishy-washy here because I guess I just don't know.
one reason for including it is that telemedicine will move to incorporating these things. It will move to incorporating artificial intelligence, and it already is. And you know, I recognize that it's not exactly the same, but and it certainly will be used in areas outside of telemedicine also. But I think it has a role, and that role will change.
I guess if you look at it like that, then it becomes a tool for telemedicine. So maybe it's more appropriate than not. You know.
I would look at it as a tool, and I'd look at it as a tool anywhere, but then so is telemedicine a tool.
It's hard for me to see what its role is here. It's vague enough that I'm not really sure what we're trying to do here.
Is it, I mean, I'm wondering if it, you know, how you can take a picture of a leaf and then figure out what plant it is using the artificial intelligence from the computer, from, you know, just on your phone. Is it so someone has a rash and they take a picture of it and they're just trying to get a diagnosis? I mean, is that what we're talking about? Without having a provider there?
Need a license.
Well, so we're using teledermatology all the time now.
Right. That's what I thought.
So there's two areas. There's two areas where artificial intelligence really can make an impact. One is in melanoma care, because artificial intelligence is shown when combined with clinical input to be better than clinical input alone or artificial intelligence alone. And that certainly in dermatology is something that can be done by telemedicine. The other place where it's been shown to be significantly improving care is with teleradiology, which is absolutely telemedicine. And I think as I say, I think we're moving into an area where this isn't the same as telemedicine because it'll be used in the office too, but it is going to be used with telemedicine and a significant part of it. And we don't have to put it in now. We can take it out. I don't have real strong feelings about this, but it does have a role here.
So in dermatology, so you could put like, for example, dermatology and radiology, but then there's all kinds of algorithms. There's things that draw information out of the medical record. There's so many ways that AI is used now, and it's expanding all the time. It's hard to know what this is relating to unless we put some examples in there of what we're trying to talk about, get at, you know?
And Dr. Roberts, I think you've changed my thinking on this. I think it fits if we're augmenting medical decision making with artificial intelligence algorithms on some remote server. We don't know where that server is, what state it's in. It's certainly not licensed to practice, but it is a tool that, I mean, it could conceivably fit within definitions of telemedicine for a consult. Are you consulting the artificial intelligence agent?
Yeah, and I think you need to understand the use of the tool and you need to understand its limitations, which is what this is suggesting. So it actually does make sense to me. That's I don't know, whatever.
I mean, I don't think it does any harm. I'm just saying that it's, to me, it's just very, very broad in all that it could imply.
So I'm fine to leave it in. Sounds like, John, you're fine. Claire's fine. Alden's fine. And who else? Scott's fine. So can we, with all our discussion, we basically are accepting the changes? Is that right?
Can I point out one more change, and that's the footnote at the bottom, page 2, Amelia. The commission has traditionally held that a pathologist or radiologist out of state reviewing images or slides on a Washington patient has to be licensed in the state of Washington. We got this question again today, and I looked at this document to see if we addressed it. We don't, so it's put it in the footnote. It's in a footnote because those activities don't always involve telemedicine. But I wanted to make it clear for people who answer the phone and have to answer this question that a pathologist or radiologist does not, unless they fit within one of these exemptions, which I don't think that they will, has to be licensed in the state of Washington. They're making a diagnosis, they're practicing medicine, they're affecting the care and treatment of a patient in Washington, and they need to be licensed. But I wanted to bring that to your attention in case you disagree.
I have a question. We commonly will send out difficult pathology questions to specific areas of the country to get them to give us a help us come to a diagnosis. We'll send them, I mean, that's a fairly common practice, and you send the slides out to the individual. Usually it's pathologist to pathologist. That's excluded now, or has been excluded, or what? We do this regularly.
That would be a second opinion under the statute and would be exempt.
Okay, all right.
Okay, any other discussion of this thing that Mike pointed out? No, can I have a motion to approve the doc? Yeah, great. Alden, second. Claire, thank you. All in favor, say aye. Anyone opposed? Great, great work on this, everyone. Thanks a lot. I think it'll be an important document. Statement, I should say. All right. Next thing up, we just continue on till we're done. The next one is number 5. It's discrimination in healthcare. I thought it was a very well-written document and wanted to open up for any comments about it. Colin?
This may come as a shock, but I have a few thoughts. On page 4, the first line, could this be read? I don't think so, but could this be read that first offense isn't enough to result in a level 3 offense? I believe the or in there makes that clear, but I just wondered if anybody else misread it the first time they read it.
I did.
Dr. Roberts, could you clarify what line you're talking about again, please?
The very first line on page 4 of 4. And let me bring it up on mine so I can get to it. Whoops, there it is. Wait a second. I think I must be. I'm sorry. I'm having trouble finding it in my document.
Were you talking about the different levels, how there is some of the statements might imply that you have to go through level 1 before you get to a level 3, and a level 1 is not exhaustive, and it kind of, on my first reading, that was my concern, is that this doesn't exhaustively cover everything, and we might have discrimination that is bad enough to be a level 3 at the first instance, and so forth.
Yeah, exactly. And I'm sorry, but I'm having trouble finding that. I thought I had it marked.
Amelia, could you scroll down just a tad so we can see level 3? Thank you.
Well, level 3 is after there's prior sanction. So that seems different than level 1 and 2. I read it that level 1 and 2 are things that people would decide about. Level 3 is a different level because it's already had its complaint and an issue. And then they imposed a sanction, and then, or anyway, that is unclear, I guess.
Yeah. It is level 3, the first line. It says deliberate discriminatory behavior or discriminatory behavior that occurs after the WMC has imposed sanctions. So if you actually read that or in there, the first part says it can be a level 3 based on really bad deliberate behavior. The second part says or if this it occurs after WMC has imposed sanctions before. But when I first read it, it looked like there wasn't any way to skip 1 and 2 and get directly to 3.
Exactly. That's how was my concern too. And where that clause, where does that refer to? Does that refer to only the right-hand side of the or does it refer to both of them? And if it refers to both of them, then we've got a problem of non-exhaustion, where level 2 requires repeated acts, and level 1 is kind of soft. It just says may be remediated with education and guidance. And I was curious whether the writer might have intended to specify that a level 1 is something that we believe can be remediated with education and guidance. And so there's a difference between the whether the language is defining or providing a function. If it's providing a function, it means something else than if it's just definitional. So that was my concern about these.
Does anyone have a suggestion for how to change it, or do you want to think about it?
I was also concerned I shouldn't say concerned. I love this. I think this is exactly the right direction, and I really love this a lot. I'm also looking at the key terms, and I'm wondering how close are we to wanting to adopt this and get it out right away, versus would we have some time to go back and tighten up some of the definitions in here. I don't mean to try to make it academic. There are just a few things I would like to propose some mild revisions to some of the key term languages for consideration.
Scott, I think it's really an important document, but I also think we really need to get it right. I also have another comment which has to do with what's at the very bottom, where it says WMC may summarily restrict a practitioner's license. And I don't think we should involve ourselves in determining whether it's a restriction or a revocation. It should be a summary action, not a summary restriction, because that will allow AG to do what AG thinks they need to do with our guidance. So I think I'd like to see us make sure we get this right.
Yeah, that sounds reasonable to me. I think Scott and Alden, you should really think about anyone else. I think we should open up to the entire commission members to look at it, because it is an important document, and it would be good to have further, additional feedback beyond these elements that were confusing.
And I want to point out that the primary author of this is Mahi Zero. She's our new equity and social justice manager. I'm not sure how many of you had the pleasure of meeting her virtually, but she's the one who drafted about 90% of this. So it's her work, and she deserves all the credit.
Well, for the number of changes that we're looking at and suggesting, this is an incredible document. This is incredibly well done.
Agree, and important. I love it.
So since I won't be there, John, maybe you could just open up to the group if has anyone, ask people to have read it and make suggestions.
Okay, and then we'll bring it back in January for the final.
Yeah.
I'm assuming Alden and Scott will submit changes to Mike and Mahi or Mahi only, or I don't, wherever they should go. I guess to both of you.
Dr. Roberts, should one of us start with a redlined version tracking changes and send it to the other?
That would be great. It would need to be in a Word document, I think, if we're going to easily do that.
Could one of us get a copy of the Word document?
Of course.
Yeah.
I look to Dr. Roberts as kind of an expert on these things as well.
Great. All right. The last item. Legend, drugs, and devices about midwives. Looks like, is this an old document and then you made a change where an update might?
No, this is a new document.
Ah.
So the department has a midwifery program. So out of the 80-something professions that DOH licenses, about half are governed by boards and commissions, and a little more than half actually are governed by the secretary. So this is a secretary profession. However, they have an advisory committee. So there's a midwifery advisory committee. Members are appointed by the secretary, and by statute, the committee consists of an obstetrician, a practicing physician, 1 certified midwife, 3 regular midwives, and a public member. And I think there's the program manager is in attendance. So if I get this wrong, she can correct me. The committee makes recommendations to the secretary, and there's a statute that lists the drugs that a midwife can administer. And it says that the secretary, after consulting with the advisory committee and the pharmacy commission and the medical commission, can add drugs or devices, can adopt rules rather that allow a midwife to purchase and use certain legend drugs and devices. So here is in front of you an existing rule on that with the advisory committee for the midwifery program, asking for your feedback on the addition of 2 items. And if you scroll down, Amelia, it's the use of ultrasounds and then later nasal swabs. So if Kathy Weed, the program manager, is available and she can be unmuted, we can get maybe perhaps more information on this.
Yep, I've already unmuted her.
Hi, everybody. Thanks. Thanks for that, Mike. I don't have much more to add than what you said. You did a good job. Thank you so much. So we really just need to consult with you guys on the 2 items that we added, the nasal swabs and the one for the limited ultrasound use. I did have one midwife on earlier, but I think she had to leave at 5. And then the second one I had lined up is now at a birth, but she said I could text her questions, which seems sort of too much of an ordeal maybe. But if you have questions or concerns or something, you know, we just really would like your feedback on these 2 items.
So I don't see how you can practice without both of these. Certainly not without the ultrasound. So I would absolutely recommend that we accept. We recommend that you accept these.
Yeah, I thought they were reasonable too.
Wonderful. Well, we appreciate that.
Yeah,
Anybody else?
Yeah, the nasopharyngeal swabs for COVID testing, is that the deal?
Well, we had that language in there initially, but then we thought it might be too limiting, so we just put for appropriate testing. So
Yeah, that's fine.
that was the basis for adding that, yeah.
Okay. I think croup is the other one that you might use them for. But that's fine. I think these are very reasonable.
Wonderful.
Do we need to do anything other than provide that feedback?
I know in the past, I've gotten a letter or something that just said, you know, thanks for, you know, letting us view the language and we think it's fine or something, but maybe I can work with Amelia on that or something.
Well, so it should come up, the whole commission was sent this, so I guess, John, you could just get comments like from tomorrow. They have any other suggestions?
Well, I did want to ask Heather if she's still on. Is this something that requires commission vote, or is this an administrative letter that would be able to come under Mr. Malden or Melanie's signature?
So I would have the full commission comment on it tomorrow. I don't know that you need to vote, but I think you can, you know, summarize a couple of the comments that these seem like reasonable additions, and then have Dr. or Mr. Malden or Melanie sign it. I think that's fine, but I would have the whole commission look at it and give comment tomorrow.
Okay, thank you.
If anyone has any, yeah.
Okay. Anything else from this meeting today?
Thank you so much.
No? Thanks, everyone. Have a good evening.
Thanks.
Thank you. Well
Okay.
done.
Safe travels, Karen.
Yeah, thanks
Yeah,
a
have
lot.
a good trip,
Thanks
Karen.
for covering tomorrow. All right. Bye-bye.
Bye now.